Thank you very much. I'm Simon Kendall. I've got the privilege to be the president of the Society for Cardiothoracic Surgery, UK and Ireland. And it's remarkable to have this collaboration with the Egyptian Society for Cardiothoracic Surgery, hosted by the Cardiothoracic Surgery Department of the Suez Canal University. And sincere thanks to the president of ESCTS, Professor Husseini Ganal, and the secretary, Professor Wabi, and for the Suez Canal University, Professor Aldamiati and Professor Amir for organising this event. We hope there's plenty of collaboration in the future. I've been asked to talk about the COVID pandemic and cardiac surgery, and I'd like to focus on our experience in the United Kingdom, which I hope is interesting for colleagues joining from the United Kingdom, but also interesting for colleagues in Egypt. We have Egyptian fellows with us, and I understand the response in Egypt was different in some ways to the UK, and I hope there's shared learning from the experience. It's just over a year ago now that the United Kingdom went into lockdown in response to the coronavirus. We were slow through January and February, and we were naive. We thought it wouldn't happen here, and there was naive optimism that it was just another mild case of flu, as it were. And rapidly we saw that London and the southeast of England were affected, and we had reports of patients following cardiac and thoracic surgery succumbing to the virus. And on a more personal level, we also had reports of medical and nursing staff suffering and succumbing to the virus, which was very alarming, and there was a great deal of fear through the cardiothoracic community. We've become very familiar with the COVID pandemic and the disease, but I think it's always worth remembering what a horrible disease it is to get badly. To be short of breath must be awful, fighting for your breath, fighting for your life. To end up in a healthcare environment surrounded by healthcare workers in PPE, and you can't hear them talking properly and you can't communicate with them effectively. And worse than that, in the United Kingdom, we didn't allow visitors. So you had no family around you, you were alone, and you were unable to say goodbye before you were put on a ventilator. And for all the healthcare staff, there was a lot of fear. We were frightened for our own health. And as surgeons, most of us have jumped that barrier, confronted that problem, in that when we operate on patients, say with HIV or hepatitis C, etc., we've already know that we put our own health at risk for the benefit of our patients. But for a lot of our colleagues in healthcare, this was a new challenge for them, and it was interesting to watch their reaction to it. So we were dealing with an unknown disease, and there were unknown treatments, and there was a lot of fear. Through March, there were various stages of getting ready for the pandemic, and each hospital had various levels of training and education. And of course, there was a lack of available viral testing. So often you had to guess on the clinical features whether the patient had COVID or not. There were reports of a lack of personal protective equipment around the United Kingdom. And our media also, to some extent, politicized the news of this. So it was hard to tell what was truth and what was exaggeration. Our cardiac intensive care units rapidly tried to prepare for the influx of COVID patients or general patients. And in effect, through April, cardiac surgical activity ceased throughout the nation as we prepared to take either general patients or COVID patients to our level 3 care. What was remarkable in lockdown was that the population stayed indoors. Patients were not presenting to their general practitioner with their cardiac symptoms. They weren't presenting to cardiology. They weren't presenting to A&E. So it wasn't just cardiac surgery that stopped, but the cath labs were quiet as well, and the coronary care units were quiet. It also brought about great responses to the challenge. I'll give you the example of the Pan-London Emergency Cardiac Surgery Service that was set up. We've heard Kelvin Dalal speak about the aortic valve, and he works in St Bartholomew's Hospital, and it was their leader, Steve Edmondson, that became chairman of this response. And the decision in our capital city was that 2 units should remain open for emergency cardiac surgery and unstable in-house patients, whereas the other 5 units all dedicated their services to help with the pandemic. We reached the concept of red, amber and green pathways, where red pathways were for patients with COVID, green pathways were COVID-free, and amber was where there was some degree of doubt whether patients were truly free of COVID or not. Through this time, when cardiac surgery was so limited, patients were then given more choice of less invasive interventions such as TAVI and PCI. I've got some data on PCI later in my talk, but certainly the data that we're getting about TAVI is that the sales of TAVI valves went up significantly last year through the pandemic, and the sales of surgical valves dropped significantly. In the health sector itself, it was interesting to observe how we struggled to come to terms with the need for us to social distance and to wear protective clothing. And there were too many examples of handovers in COVID intensive cares being done with 10, 15 colleagues in a small room, no masks, no PPE, no social distancing. And gradually the healthcare community has begun to understand its responsibility in adopting safe practice. Our junior surgeons in the United Kingdom, our trainees, they effectively had their training stopped, and most of them were redeployed to areas of need, such as intensive care and high dependency unit, to the COVID wards. Some were allocated to line insertion if they had those competencies, or offering a chest drain service. And our allied health professionals in cardiac surgery, the surgical care practitioners, the advanced care practitioners, they were redeployed to ITU, to the COVID wards, to HDU. And these, for our junior surgeons and our allied health professionals, this was extremely challenging. They were working with a disease that they didn't fully understand, that we were getting to terms with. At the time, they were putting their own health at risk, and they were put into situations watching patients struggle with health, often passing away, unable to support them. Consultant surgeons were used in a variety of ways. Some were redeployed to intensive care and high dependency, some to the COVID wards. In St Thomas's, for instance, they offered a drain service to the vast number of level 3 cases. But sadly for me as president, I think a significant number of us were not used at all. And I think that to some extent, that's a wasted resource. We'll be hearing later from David Jenkins this afternoon about mechanical support, but the COVID pandemic was a significant challenge for those cardiothoracic centres that offer ECMO support. For instance, Harefield, Leicester, Papworth, Wythenshawe, Freeman, Glasgow. And of course, patients were selected. These tended to be younger patients, fitter patients who'd succumbed to COVID. And it was remarkable how all these ECMO centres expanded their programme, doubling it, trebling it, in the hope to help these patients. When the pandemic first started, it was thought that ECMO was not very successful, but during the first wave, it appeared that it was 50% successful at getting patients through, which gave us renewed enthusiasm for its redeployment in the second wave in January. I've already mentioned alternative treatments for unstable patients, and this chart, this graph shows the odds ratio of getting PCI versus CABG, and see how the odds of getting a PCI significantly increased during the pandemic. So at the front line, it was busy, it was frightening, and there was a lot of admiration. But equally, there were large parts of the health service that were very quiet, and a lot of us were standing idle watching the pandemic challenge. My presidency started last March as lockdown commenced, and I was very impressed by the collaboration of the professional organisations and the health service to try and look after patients through this time, to prioritise patients and to look after our staff. And here are some of the associations that I was dealing with: the Federation of Surgical Specialties, the Royal College of Anaesthetists, the Royal College of Radiology, our own Association of Cardiothoracic Anaesthetists and Critical Care, the Society of Clinical Perfusion Scientists, scientists, and all 4 Royal Colleges of Surgeons. And as a professional society, we try to help our members as best as possible to educate them in the rapidly evolving arena. So here are some examples of the publications. 23rd of March, just over a year ago, our joint theatre guidance for anaesthetists and perfusionists, which included guidance about aerosol generating procedures and protective equipment. For instance, on the 22nd of April, the recommendations about screening when we were recommending CT scans before any thoracic or cardiac procedure. So we have tried to keep our members safe, and we've tried to keep them up to current practice. So as I said, in April, cardiac surgery effectively shut down last year. There were emergencies only. And when we did operate, we were learning how to operate in full personal protective equipment, which was very challenging. Often the anaesthetic room was left empty because induction was done in theatre. And if you did get to 2 cases a day in theatre, it was very time consuming because it was not possible to increase or decrease the time of turnaround. In May and June, we started to restart our cardiac programs. There was better testing for COVID. And I think there began to be an understanding that healthcare staff had similar risks to the general population, because during March and April, there was a fear that we were higher risk. I observed that our socialised health system had been chronically under-resourced and morale was chronically low. And having survived the first wave, there was passive reluctance to resume the same level of work that we'd endured before the pandemic. As the year progressed, the cardiac programs gradually began resembling normal, but never got back to full activity. But then after schools and universities went back in September, October, the number of cases were increasing. And as November came, there was a renewed lockdown. In December, the vaccine arrived, and it was interesting that the United Kingdom was the first to employ it. And then at Christmas, social interactions were allowed. And there is no doubt that the Kent variant rapidly went through the population at that time. So that in January, we had our next lockdown. The number of cases in January far exceeded the number of cases back in March and April. But this time, the concept of green, amber, red pathways, personal protective equipment, the treatment for COVID, because all of that was ingrained, it was easier to cope with. And the best example I have for you all and how bad January was that St Thomas's Hospital in London normally have 70 to 80 level 3 care beds. And during January, they had 240 level 3 patients. And yet they still only had 80 nurses per shift. The cardiac surgeons were offering a chest drain service, the vascular surgeons offering line access. And it is hard to imagine how all those centres endured such intense care through January and February. Outside the main areas that are affected, most cardiac centres have maintained in-house urgent activity, but cardiac surgery has significantly suffered. Looking back at the year, we suspect there's been a 60% reduction in cardiac surgery altogether, and we'll await for the annual data to get more accurate figures. But what have we learnt? What are the opportunities that have been created through the pandemic? We've learned that we can do virtual consultations with our patients for their review appointments. And if there are issues with wounds, it's possible to send photographs. And if necessary, it is possible to organise a face-to-face consultation. But this significantly saves the patient and their family travel, trying to wait in a consultation room, etc. We've also moved to virtual new consultations as well, and they're remarkably effective as well. But there is still a definite need for a face-to-face meeting with the patient before their surgery. All visiting in hospitals has been banned for a year, which has been difficult for patients who end up with morbidities and struggling. But equally, it's fascinating to see the patients learning how to keep in contact with all their friends and family using their phones and their iPads. For our own organisation, We traditionally, before the pandemic, had to meet in a room for a multidisciplinary meeting. And we've now learned that virtual MDMs are incredibly effective and they actually get more attendance. And in terms of working as a network, there is definite potential after the pandemic to continue virtual MDMs so that you can link up with the district general hospitals with the hubs. Virtual organisational meetings in your own unit, in your hospital, regional, national, even international. So much time is saved not having to travel, so many accommodation costs and travel costs, and yet the meetings are probably just as effective. Virtual education has been a revelation. This webinar is just one example of what we're learning is possible. In the society, in SCTS, we've been giving education to our national trainees to the exclusion, sadly, of our trust-appointed doctors in the hospital, our trust-appointed surgeons. And it's shown us that we can give equality of education, and we're now looking to provide education for all members of our society. And the other amazing advancement that we've witnessed is so many vaccines developed and implemented in such a short space of time. The Pfizer vaccine based on messenger RNA is revolutionary. Messenger RNA was not stable enough to use a decade ago. And it is clearly exciting to see what this biotechnology can be used for in terms of cancer treatment in the future. A couple of other things I'd like to mention before I finish. In the United Kingdom, we have a very refined national cardiac surgical audit that's developed over the years. But the COVID pandemic has been a severe disruptor to this steady state. The number of cases has dropped significantly, so the denominator's dropped, and the case mix has altered significantly. And we felt that when we published the 2017-2020 audit cycle, it may not be appropriate to include the outcomes of March last year as the pandemic started. So therefore, we moved the audit cycle back a whole month so that the COVID impact will be excluded. Looking forward, we're also considering what's the relevance now of publishing consultant level outcomes. As I've mentioned, with the denominator per consultant dropping so significantly, with the case mix changing so much, it is probably not appropriate to publish consultant outcomes at this stage. And this coincides with our society's change in the audit starting next week from its focus on consultant outcomes to the whole unit and the whole patient pathway. And finally, coming out of the pandemic, we have to be very cognizant and compassionate to our anaesthetic and intensive care colleagues and nurses on our intensive cares, the difficult year they have, the difficult it is for them to work in PPE for every shift. And we can't expect them to resume full cardiac surgical activity too quickly. And I do wonder for all of us whether this is an opportunity for us to embrace enhanced recovery after surgery. So we use our level 3 beds to the best effect, improve the patient experience, decrease their complications, and hopefully make best use of our level 3 beds and decrease our cancellation rate. So for my last slide, I think it's worth reflecting in our own specialty of cardiac surgery, the severe impact for our surgeons in training, that they've lost a year of their training, and we've got to try and make that up to them. And also the impact on our allied health professionals being redeployed and what they've endured. And especially to our colleagues in intensive care who've endured an appalling year. So thank you very much for listening. I'm very happy to take questions, and thank you for the invitation to speak. Thank you.